HYE 3.0. This is a discussion on hospital planning and designing, accountable consulting and mentoring. So we have our speakers on stage, our moderator, Dr. Y.P. Bhatia. I'll hand it over to him to steer this discussion forward. Over to you, Dr. Bhatia.
Thank you so much for inviting us for this very interesting session. I think the session which has been talked about accountability and things like that, and I've been asked to moderate. I think I have a privilege of, having been into the hospital designing as well as into the hospital operations, and probably I can talk a little more about it in that fashion because I can tell you that overall, with almost more than 3 decades of my career, where I've been involved in the hospital operations, whenever we have any operational difficulty, whenever we have any operational problems, whenever we have issues relating to the high maintenance costs, whenever we have any issue related to expandability, whenever we have any issue related to accommodating new equipment, whom do we blame? Here my friends are there, who you got to blame. Because ultimately they say, "Arey yaar, architect ne kya kar diya? Architect ne kya bana diya?" And this is exactly what I'm going to be talking about, discussing in this session today, where we are moderating, that when we are talking about the accountability of our planning process, the whole thing what we are talking at accountable hospital planning and designing. The concept where we say, मैंने तो बनाना है, चलाना किसी और ने है, is something which doesn't actually start and end over there. We are creating a hospital which is going to operate, which is going to expand, which is going to adjust to the growing needs of the organization. And ultimately, it has to run in a cost-effective manner. In the last discussion, in the last panel discussion, we were discussing about cost cutting. I don't think we are talking about cost cutting. We are talking of cost optimization to make sure that what you have made actually functions also for the purpose for which it has been done. And it starts from right from the day one. When you are talking of, when we talk about creating a feasibility, we talk about creating a DPR, and most of the time we are talking about DPR being made for the banking purposes, for taking a loan. But what actually you are looking at is the overall socio-economic demographics which are going to support the hospital in its operations. What does that mean? Are we designing the hospital for the community for which it has been planned? Are we working on something on which ultimately, I have a number of examples, Nandini is here and I won't name the hospital, but there are hospitals where the hospitals were projected as a very, very hi-fi hospital treating the celebrities and everything, located in an area where there's a middle income group population. Ultimately, people for whom you have made the hospital, they didn't come to the hospital because they thought this hospital is not meant for us. So all these factors put together, so what we are really talking about is to create an architectural planning which also is cost effective because it's going to be working on the working capital and sustainability of the organization. And also, ultimately, the expansion, what is like happened in the pandemic, the technical advancement which are happening all over the world, and how the new medical technologies are going to be putting together. The medical value tourism, which is now slowly becoming an integral part, though my personal opinion always has been that medical value tourism is only an icing on the cake. The cake remains your own population, your local population, because ultimately they are going to sustain you. That itself is MVT is a bonus which you can probably put together. Environmental social governance, the new concepts of telemedicine, this thing. And of course, while keeping all this, the architect's challenges, we expect them that they'll follow the evidence-based hospital design also. We expect them that they will, all that we talk about the form follows function, all the basic principles, and all the codal requirements, which was being mentioned in the last meeting, last panel discussion, where the interpretations are very difficult to do that. The fine print interpretations are so much of issues and you are not able to understand why they have been put together. There have been a lot of sessions, lot of talks, lot of sessions which have been put together to inform people. People do come tell you that my interpretation is so and so, but when you want the reply in writing, no one will give you that. I had a discussion with one of these very eminent fire safety panel, and ultimately they said, yes, this is what the interpretation is. After that, I wrote to all of them at least 10 times. They said, why you are asking? Let an architect ask me, we'll give a reply. Let so-and-so ask, we'll give a reply. Let so-and-so ask. When it will come from top, we'll give a reply. Ultimately, there was no reply. So, from that point of view, these are the challenges. We talk about accountable hospital design and planning. We talked about mentoring. We talked about accountability. And ultimately, a small little aspect, which, of course, comes from the architect's point of view also. They, by themselves, whether, they all are eminent strategic designers that we have. But within the organization, there are a number of youngsters who do the job. And ultimately, people at the top have to take the accountability of that. So how that mentoring thing happens to be taken care of? Because finally, it's not that youngster who is responsible. You are responsible for it being delivered. Rather than putting questions to each panelist, because my other two panelists are not available, I have generalized all the points in what we were discussing. And I would request, I think I'll start with Nandini, and then we move to Shamit and take the responses.
Thank you. Thank you, sir. First of all, I must say there are stalwarts sitting over here, Chandrasekhar sir. So it's going to be quite a tough one because everybody has practically spoken everything about what a good hospital should be, fire compartmentalization, etc. Nevertheless, we were shared a brief, and I'm going to be speaking about certain things where we architects have gone about planning in ways of standardized formats and requirements of the way a hospital should ideally be designed with respect to each room being put together, which is a space program, functional program, etc. But when Dr. Bhatia just spoke about cost optimization, that is something very important which comes up for us to establish at the beginning itself, which does come from ways where we plan a kind of a strategy to take the building, the hospital building forward, which suits the purpose of the stakeholders, the investors. Okay, now coming to what is connected with this, my personal understanding is that I would actually design spaces where I would want to be. How it appeals to you as an architect, as a human being, we need to be there. How it appeals to a patient when I'm a patient, I need to be there. I need to understand all those emotions, those feelings. We need to design a hospital for patients, staff, workers who comes in, goes out. We have to make it humane. It should work in a way that the air conditioning spaces are comfortable, they're designed as per standards and codes and guidelines need to be weaved in with respect, of course, with all the engineers. We at our company, HOSMAC, we have an engineering department, anything we need, and we don't waver, we architects don't waver, which is against what I think Engineer Shruti Goyal said, to which I think Manu Malhotra also did say that our hands are tied at times. And I must also convey that we architects also get costs cut. Our costs are cut. We don't get to design everything. जैसे नर्सिंग होम बनाया तो उसमें 2 सीढ़ियाँ नहीं दी, एक ही सीढ़ी है, but it has to be filled with the number of beds. We've done all that, but we do it with a lot of reluctance. Well, it's the cost market which is forcing us to do. And there are times when we are actually going against our management also, but we have to follow. Okay, I'm going to go and touch upon some other factors for hospital and planning. So we did speak about how the functional programming really makes a difference, and that comes from a lot of experience. There are architects who are not able to put in the best of rooms which are required for a department, so it is necessary to follow a standard. Dr. Chandrasekhar had mentioned about HFG. It's a very powerful tool. And well, we have the experience and so many years. HOSMAC is 27, 28 years old. But when we teach our architects in the office, we do make this guideline kind of a study tool to start from. One, it's very easily available on the net. So it is designed around patient-centric ideas and how even from the clinical perspective, everything that needs to go into an isolation room or an operation theater or a cath lab, everything is there. So it is very necessary to design as per guidelines, and nevertheless, again, coming back to say that we must experience the room for ourselves. That's how we architects move. Then coming to a very basic factor of hospital design, there is something known as standardization of grids. The grid is very sacrosanct in architecture for hospital design. There was a conversation why perhaps, I think Dr. Bhatia only shared with us perhaps how a hotel or a mall gets converted into a hospital, and at the same time, why not the reverse way? It's all possible. Well, a hospital must always have spaces which can be changed, because change is something which the departments evolve. There are greater technologies, better equipment. We need to design a flexible grid, but then the grid also comes from experience. We design hospitals from upward down, from the basement then and back to OT. So the OTs must be accommodated in the same grid. So we've spoken about upfront planning, which I just said that we should have a project design report, but not a basis. Basis report would be for MEP services, but an architectural briefing must already be beforehand and make it richer to design a hospital to enable the owner, the stakeholders to follow what and how they have been practicing. Now, this is a complete team effort. It's not just the architect. There is ASMEPFID, which is architecture, structure, MEP services, and interior design. Now, this actually term is for Revit, which is the software. So let me move quickly to technology. Technology is something which enhances our ways of working. It's a tool. And we architects make use of the coordination which goes on into a hospital with the help of technology, and the other consultants also come on the same platform. So this also brings about the value, how we can save energy in the building as we design through the technologies of architecture or MEP or calculations or even structure, civil, where we save on the cost of civil construction, and it is through technology. So an advancement in technology is something which is of great value to everybody, everybody. I mean, Dr. Chandrasekhar was again saying that, the examples he gave where robots were brought in, are being brought in, and a machine which does the entire health checkup in one go. So the advancement in equipment technology, our style of architecture, work technology, or let us say the engineering MEP service, everything combined together will give you a wholesome, a better hospital, and of course research. But that is something which is individual. So I'm just coming to touch upon how beautiful this world of healthcare planning is. And it really is service to man, and our honesty, our dedication, plus knowledge will do wonders in this field. Now, let me quickly just close this discussion by saying that the form and the function, and the function follows the form follows the function, I'm sorry. So what goes on inside, the way ICUs are planned, again, Dr. Chandrasekhar gave an example of the ICU, very beautiful. And then the design building for the patient and staff, finally, we must see how we orient the building so that we minimize the use of glass, which is moving towards an aware green building. अब ऐसा है कि foreign countries में तो हम लोग बहुत कांच देते हैं building के बाहर, but then the technology or their climate is very different. We should take from the way buildings are built in India. Now, historically, there were so many forts that we saw which had very thick walls, and yet the temperature inside the building did well. So we are a hot and dry country, and if we are going to put glass everywhere, there's going to be capital cost, there's going to be maintenance cost, and blinds we got to put because the architect has not oriented the building, the hospital building in the correct angle for sun to be kind of evaded or not to be absorbed by the building. So what I'm trying to say is, let us, or we architects, need to understand that we need to design the building with the comfort level of the land. That is how our buildings will be green, and not just go for a glass building. Then we must not, this is my last point, compromise on MEP service spaces. Just put your foot down. We don't compromise. It just comes to bite later. There is more money which goes into fixing that problem for the whole project. And connected with this is, again, spaces for carts, wheelchairs, dirty utility, good-sized dirty utility rooms. I mean, I'm just getting a little, going a little internal. I'm just trying to say, we architects need to plan for the human purpose, and we will do well. Thank you.
Thank you, Nandini. Thank you so much to take us through the whole process. We talked about accountability, accountable consulting at each step. There has to be a process of self-accountability in the organization, because as far as the promoter is concerned, organization is concerned, many of the time their level of awareness about all this, the impact of all this is going to be probably not so strong. So we create our own self-assessment mechanism or self-accountability mechanism, probably a checklist at every stage. That's what works a lot in making it happen. More so because ultimately as senior architects, we are working on it. We are even aware about it. But the youngster who is working on the nitty-gritties, his interpretation or conceptual knowledge are otherwise sometimes very, very limited. And don't mind my saying it, but many times I have seen that when a senior architect is actually presenting, so rather than accepting that this is something which has happened, they try to defend the youngster, what they have done, because of whatever reason, and ultimately resulting into a disastrous situation later on. With this, I request Shamit, who comes with a lot of experience on many of the points which I have said, so his views on that.
So, thank you HPI and Medgate for inviting me to this panel discussion. Very difficult to say things after Dr. Chandrasekhar has spoken because he covers most of the points. Coming to your point, Dr. Bhatia, for accountability and how juniors work. So first and foremost, there are certain regulatory requirements for any project. In terms of designing, you have the IPHS guidelines, or you have the NABH accreditation systems that need to be adhered to. Now you even have the NQS guidelines, which are, as an architect, very difficult to comprehend and translate, but You need to make sure that the quality of healthcare that is going to be provided is taken care of at the design stage itself. And besides these, you have the National Building Code. The last session talked about fire safety. So it's not only fire safety, it's structural safety, lifts. So anything that goes into the designing of a building has been defined in the National Building Code that needs to be adhered to. Keeping these regulatory things in mind is, and on record is very important. To achieve all this, the IPHS, NABH, NBC, any project has to go through a multidisciplinary approach. As only an architect, if I say I can design the building completely without anybody else's help, it's a wrong statement. I need doctors, I need engineers, I need paramedical staff. We need input from all the stakeholders. And unless we have inputs from all the stakeholders, we cannot design a good building. The MEP engineers guide us in terms of life safety, structural safety, other safeties. As architects, we design buildings keeping in mind the other NABH regulations. Doctors guide us on interpretation of the IPHS guidelines, NQAS guidelines. So unless we have a multidisciplinary approach, a project cannot be implemented properly. To achieve this, we need to have a system within our own offices of internal and external audits. Auditing in terms of what my junior has done, has he implemented all the regulations properly or not, how the various things to be implemented. Not only it has to be internally audited, it has to be preferably audited at an external level also as a third party who can come in at various stages and make sure that what we have designed is meeting all the requirements. Documentation is very important to make sure that all the compliances are being met through, and it is, as Dr. Bhatia said, a junior architect makes a mistake and then somebody else has to come and defend it without rhyme or reason. So that should, once you have documentation properly done and ensured that all the compliances are there, that problem will not arise. Peer reviews like internal and external audits. And another aspect is continuous training of our staff. They need to be exposed to various continuous education programs on healthcare design. They should attend such conferences, such events where we talk about healthcare planning. So these are certain things which I feel are very important to ensure that planning does not go astray, even if it is left in the hands of junior architects. That system has to be there in place to make sure that mistakes don't happen.
Thank you, Shamit. These are, I think, a lot of words of wisdom out of the experience which you have gained in the past so many years. I think I've known him for more than 2 decades now. And sometimes feel that when I talk about it, I said 2 decades, 3 decades, not the years. In fact, Dr. Chandrasekhar in the meeting other day said, I have known Dr. Bhatia for more than 3 decades now. So I think we are getting into decadal system of discussion. And I think whatever we said, again I repeat, for us, who are in the operations, the life is made difficult or easy by the people who have planned the organization. So that integration of hospital planning and operations is the one which is getting into the accountability. And when I say mentoring, it's two-way process. Because people who operate, they don't understand architecture to that extent. And many times, people who plan, they don't understand operations to that extent. So somewhere that integration into the accountability principles of the planning is something which may be a way forward, that when we talk of school of plannings, maybe some people from operations can go and talk about it. And when you talk about operation, some people from planning can go and talk about it. So that will probably give a lot of insight into the way forward the thing can happen. Thank you so much. Thanks for being such a patient audience. And of course, grateful thanks to Nandini and Shamit for their very, very valuable inputs. Thank you so much. Yeah.
Yeah, so I am Colonel Parmar. As a Group CEO of chains of hospitals, I have been intimately involved in the designing of healthcare facilities. So we all view a hospital as a holistic facility for the overall healing of a patient. As part of my training, I was in Singapore with one of the best hospital chains, Parkway Pantai. So I had the privilege of visiting all the 4 hospitals. All 4 are JCI accredited. And Mount Novena is really a 7-star, hospital. So, today I'm so happy to hear that, we are all talking about evidence-based design and something which was missing from the healthcare facilities earlier. Ergonomically designed facilities, making use of the ambient light. So in this hospital, when I saw, beautiful landscaping, the hospital also had a patented fragrance, right? Even the profitability of a hospital, you cannot just build Taj Mahal and then, think of breaking even in 3 to 4 years. You have to plan it from the beginning, from the design stage itself. And, one of the challenges which when I visit the government hospital, because I work closely with them also, is that the design aspects are quite missed there. There are a lot of spaces wasted. The lowest bidder gets, the contract. And the designing itself is so poor that the construction actually complements it and makes it even worse. So while the private sector is really growing and looking into evidence-based designs, all the new hospitals are, which are coming up are beautifully designed. But I think the government services also must bring up themselves to that standard, and NABH accreditations, which they have started for the government hospitals, is really a right step in that direction. Thank you.
Thank you so much, sir, for your comments. And I think because of time, we'll take the last question and then we'll...
Thank you. Lot of emphasis has been put on MEP part, structure part, and other stuff, but equipment planning hasn't been mentioned in most of the topics. And as an architect, one might be aware of all the other stuff, such as MEP structures and all. But one thing which is very technical and lacking in terms of knowledge is basically equipments. So I wanted to ask, how do you address that equipment planning part? Because that has got a lot of complications. Like, for example, equipment guy had come and suggested a machine, MRI machine. And I had placed it according to my knowledge. Like, it was appropriate also in terms of radiations and all. So later on, I didn't know about the intensity of the radiations and all. And then later on, the other equipment guy came and told if a pacemaker is going by, then how it's going to have a severe effect on it. So one thing which I feel is more important as an architect is also equipment planning. So that address hasn't been much discussed in this conversation. So I would like you to add more on it. Thank you.
So when I talked about multidisciplinary approach, it also includes equipment suppliers and equipment planning also. As you very rightly said, one of our projects in the initial stages, we designed an MRI on a particular floor, and there was an ICU on the upper floor. Without realizing that what effect the electromagnetic radiations will have on the monitors of the ICU on the upper floor. So, one, it is a learning experience. Second, the multidisciplinary approach ensures that such problems do not arise. One would not keep an ICU unit right over an MRI floor. How the RF cage functions, how it ensures that radiation doesn't go out, or other aspects. So that is very important. And though I did not mention specifically an equipment supplier, but in the multidisciplinary approach, the equipment suppliers are an important and crucial part of the hospital planning process. And it is very essential that all stakeholders are kept in the loop when designing hospitals. Though a particular equipment might not be, brand may not have been decided at a certain stage, that I will go in for a GE machine or a Siemens machine. They have their own specific requirements, but when you design for a generic space, and as the equipment gets finalized, you fine-tune it for that.
Thank you, Shamit. Thank you so much, and thanks a lot for the question. I'll sum up in just 3 things which I generally talk about all these events is, And I always say in the school, in the planning and architectural events also, that are we designing a monument or a hospital building? Are we thinking of a beautiful hospital or a good hospital? Are we talking hospital which is architect friendly or architect delight, or a architect, patient, staff and attendant delight? So these are the questions which I ask, and I say, why it can't be both? Why it can't be beautiful and good both? Why it can't be monumental and a hospital building both? And why it can't be friendly to all of us? Ultimately, when you look for a spouse, you look for the beauty and the goodness both. So why you have it at every other place? Thank you so much.
Thank you to our speakers on stage for this discussion. I would request Mr. Manish Rastogi and Afzalji to please come on stage and present our speakers with a memento and a plant. We want to thank them for coming here and sharing their expertise with everyone, important points raised which everyone can learn from. So I request Afzalji and Rastogi to please present a plant and a memento to Dr. YP Bhatia, Managing Director, Astron Hospital and Healthcare Consultants. A plant and a memento for Mr. Shamit Manchanda, Chief Healthcare Architect, Manchanda Associates. And a memento and plant for architect Nandini Bazaz. I request all of you to please gather for a group photograph. Thank you to all our speakers.